Thank you and good afternoon. I'm Catherine Santoro, Senior Director of Programming at the National Institute for Healthcare Management Foundation. On behalf of NIHCM, thank you for joining us today for this discussion on the future of artificial intelligence in healthcare. This webinar is part of NIHCM's Artificial Intelligence webinar series, where we are sharing research and expert perspectives on the integration of artificial intelligence in healthcare and its impact on patients' lives, care delivery, and health equity. In our next webinar in this series, we'll explore the impact of AI on health equity more in depth. NIHCM's previous work on AI includes supporting the work of Ziad Obermeyer and colleagues through our research grant program. We'll hear more later about how their discovery of unintentional racial bias in a commonly used algorithm has brought about important changes in how healthcare needs are assessed and met. Today, we're joined by a prestigious panel of experts to learn about the opportunities and challenges of using AI in healthcare, examine real-world use cases, and consider the ethical and legal implications of integrating AI into healthcare. Before we hear from them, I'd like to thank NIHCM's President and CEO, Nancy Chalkley, and the NIHCM team who helped to convene today's event. You can find biographical information for our speakers, along with today's agenda and copies of their slides on our website. Closed captioning information for today's event can also be found on our website and in the webinar chat. We also invite you to join the conversation on social media using the hashtag AITechNIHCM, which is NIHCM. I'm now pleased to introduce our first speaker, Dr. Michael Matheny. Michael is the director of the Center for Improving the Public's Health with Informatics and professor in biomedical informatics, medicine, and biostatistics at the Vanderbilt University Medical Center. Over the course of his career, Michael has produced academic work on the topics of natural language processing, risk prediction modeling, and signal detection for machine learning methods. We're so grateful to have him with us today to share his perspective and his research. Michael?
Thank you. I want to first thank you, Catherine, and NIHCM for the opportunity to come present today. It's a topic that's been near and dear to my heart for many years. So let's dive right in. Next slide. Next slide. So I don't have any conflicts of interest to disclose relative to any of the tools or technologies, and all of the funding I received is from the FDA, NIH, or DoD, or VA. Next slide. So to dive right in, I'm sure everyone has heard the saying that there's been, just unprecedented and tremendous growth in the volume and complexity of medical scientific data and in volume and complexity of patient data itself. But when I went around, I'm a data-driven person and being an informatician, and I went around trying to really get a good example of that for discussion. One of the things I found that was really interesting was a systematic review looking at oncology clinical trial guidelines, essentially looking at the guidelines across different cancer types. And what they found was essentially an exponential growth in both the volume of documentation, the data and information required to deliver the clinical practice guidelines, and an exponential growth in the amount of scientific knowledge and references that were required to deliver that information, which is fascinating. And I thought was a really nice concrete example. Beyond that sort of deluge of scientific information that clinical healthcare providers are responsible for and increasingly having challenges addressing, even when you take something as straightforward as a clinical practice reminder, everyone all patients with coronary artery disease should be on a cholesterol medicine in the statin class if possible. You look across the nation and you can see a tremendous amount of practice variability in patients that are actually receiving that, as shown on the right-hand side of this slide. And that holds true for many other conditions, such as bronchodilator therapies in patients with COPD and many others. So when facing these challenges, really, we need help in managing all of this information. Next slide. And so, that's really why we're here today, is that artificial intelligence and machine learning technologies really hold huge promise in being able to bridge some of these gaps, address some of the challenges, and help improve healthcare and healthcare delivery. And beyond just the the frame of reference that I deal with primarily in my career. There's work going on in ambient AI, which is attempting to draft provider notes without providers having to type anything using recorded information. There's basic discovery and science and drug discovery, image processing, clinical decision support, and even in rare cases, autonomous AI applications that have been given approval by the FDA to operate without physician interpretation. Next slide. So with all of this excitement and promise and opportunity, what comes with it is a challenge of too much expectations and too much hype. And in fact, the artificial intelligence community has seen prior instances where there was excitement over technology, everyone rushed out to sort of use it, and then there were some really bad occurrences that soured the public's perception of the use of these tools, and they saw a drastic decline in use. And so what I find fascinating here is I've been watching the Gartner hype cycle over the years sort of represent this for the public. And in 2019, deep learning, machine learning, and natural language processing were all technologies that were really of high interest, a lot of investment, a lot of excitement. And you fast forward that just 4 years, and you see deep learning, machine learning, natural language processing aren't even on the graph as individual subdisciplines. And in fact, generative AI has sort of taken all of the oxygen in the room for excitement and interest in the general AI machine learning technology, even though it's still true that all of these other older technologies are still operating and have a lot of promise. Next slide. So I can't cover the waterfront, and I think each of the panelists will present their own view on things. I'm just going to give a few examples of some of the challenges that we face when we're trying to implement AI in healthcare. And the example that I like to use here is looking at the pulse oximeter. So there was a group during the pandemic that looked at critical care patients and essentially evaluated the pulse oximeter readings with the arterial blood gas, which is a reference standard to be able to detect the oxygen. And the way that artificial intelligence is used in these applications is that a red laser is sort of shown through the finger, and in the wavelengths that get through the finger are measured on the other side. What they found that among Black and African American patients is that the pulse oximeter was systematically reading lower than the actual, it was reading higher than the actual oxygen levels in the blood, which gave false confidence that the patient had sufficient oxygenation when in fact a portion of them didn't, and that was significantly higher in that subpopulation. And this is largely due to the fact that the training data that was used for these pulse oximeters was largely white and Caucasian population. And it's really relevant to today's conversation because just this week, the FDA has convened an expert panel that's going through the data and information around pulse oximeters, seeking to provide guidance and recommendations around what can be done to make these more accurate across different skin tones. Next slide. And so work that we've done also to highlight not only challenges in training data, but also challenges in applying these applications and algorithms over time. We took a series of different machine learning algorithms and looked at essentially changes over time in event rates for outcomes in associations between different features in the healthcare, as well as differences in case mix changes over time that are delivered. We found that all of these algorithms were susceptible to drift and performance problems over time. Even though deep learning and neural networks were the least affected, they were still affected. And this can have significant safety events in clinical practice. Next slide. And so I can't do a presentation without generative AI. And so I think it's really important to note that ChatGPT and large language models are not immune to any of these issues. In fact, it's known that if you try to do a prompt response for these algorithms and you ask it something after the end of its training data, it has challenges inferring and providing recommendations. It's also true, if you look on the right-hand side of the slide, a group looked at ChatGPT 3.5 and 4 across 8 different tasks, and basically evaluating the accuracy of those tasks compared to manual validation, and found that even among 3 months of training updates to these algorithms, the accuracy among different tasks varied widely. And you can imagine when you're trying to deploy this in clinical production systems that the safety of these is going to be even more challenging for the healthcare systems and for the FDA to regulate in the setting of continuous improvement of these algorithms. And lastly, I just want to highlight that these the generative AI tools have sort of rushed onto the scene, but really tens of thousands of human hours are spent doing manual labeling and reinforcement learning to remove inappropriate, bias, and derogatory responses that have enabled the gold rush that is generative AI. Next slide. And so work that we began with the National Academy that I co-led with others on the slide back in 2018 sought to sort of do an environmental scan of healthcare and artificial intelligence, provide some general recommendations and guidance around opportunities. And even though the field has moved forward at light speed since 2019 when this was published, I still think one of my favorite parts of that was a group of us that got together and made some recommendations around guidelines for best practices of implementing AI in healthcare. And we drew from multiple different disciplines: learning, health systems, implementation science, user-centered design, and human-computer interaction. And then work with Dr. Dwanka Mullen later overlaid the lens of racial justice, health equity, and ethical AI into the framework. And so I'm not going to go into too much detail for time, other than to say, I think the most important concepts are that it's really critical to understand what you want to change or what needs to be fixed, and then evaluate that in the context of the workflow, the stakeholders, the end users that are going to be affected, the patients, the caregivers. It may be that AI is not the right tool for this. And so I think one of the challenges in generative AI right now is we're using the tool, seeking use cases for the tool, when a better practice is identify the problem that you need and then apply the technologies that are needed for that to make healthcare safer and more effective. But given that if you do choose AI or machine learning technologies, you adapt it, integrate it into the system, you deploy it into production practice and monitor it and make sure it's safe. And then you do ongoing monitoring in order to prevent performance decay, also with an eye to when the tool needs to come out of service, when it's no longer relevant or the prediction itself or performance are degrading. Next slide, please. And so I'm just briefly going to go through two works that we've done in the past year with a lens towards relevance for this panel for AI and for the implementation lifecycle. This was some work that a group of us did at Dartmouth and Vanderbilt, looking at and the VA, but essentially using 20 cardiac catheterization labs in the VA as the research site. We randomized 2 interventions in intensive quality improvement coaching, as well as informatics visualization, risk adjustment dashboard that sort of surveilled the cath labs, provided machine learning based assessments of risk, along with ability to sort of view their data. Some sites received one, some sites received other, some sites received both. And at the end of the 18 months of intervention, which the sites weren't required to make any changes whatsoever, they were empowered to do whatever was right for their practice, for their workflow. We saw that the odds ratio was 0.54 for the incidence of acute kidney injury following catheterization, the significant reduction after implementation of these tools. And I think from an AI perspective, one of the coolest things about this was that a priori, Dr. Davis had developed a set of AI algorithms to watch the other AI algorithms that were conducting the risk adjustment, to basically monitor them for performance degradation and update them to maintain performance. We started this trial before the pandemic and went through the pandemic, and the only way that we were able to successfully complete this was because of the algorithms watching the other algorithms and maintaining the performance of the system as the trial went on. And so I was very grateful that we sort of a priori implemented that during the beginning of the trial. Next slide. And lastly, shifting from a population-based frame to a more of a provider-patient dyad frame, I have a lot of interest in precision clinical decision support, in which context-relevant information is delivered about the patient beyond just a regular clinical reminder. So this was some work that we did adapting natural language processing tools, older technologies tools, to basically summarize for people with coronary artery disease, looking at the need for a statin cholesterol medicine. If they weren't on that medicine, they basically went in, looked at all the prior tries that they gave of that medicine, any adverse events documented in the chart, why they had coronary artery disease, gave the providers information about where to find all of that information and recommendations on what to do. We injected that directly into the electronic health record for the primary care providers. Essentially, we tried to do that per their wishes right before the primary care clinical encounter, in order to sort of be appropriate with the workflow. I mean, what we saw was that if that was done properly, 1 in 10 reminders resulted in an increased statin renewal or start. And as you can see in the bottom, it was much preferred if it was done right before the encounter. There were situations where we had to give that information in between encounters, and because that wasn't as aligned with the workflow, there were challenges therein. And so, the other thing I would say in conclusion is I think large language models have the capacity to summarize, conduct information synthesis, and summarize care in a way that will allow this sort of work that took years to put together much more scalability and deployability. So next slide. So I thank you very much for your time. Next slide. I'm happy to answer questions at the end, and I'll pass it to the next panelist. Thank you.
Thank you so much, Michael, for sharing some of your research on the opportunities and challenges associated with deploying AI in clinical settings. Next, we will hear from Svetlana Bender. Lana serves as the Vice President of AI and Behavioral Science for GuideWell and Florida Blue. Lana leads generative AI strategy, vision, and responsible adoption throughout the organization and its partnerships in order to improve the well-being and decision-making of their customers. We're so honored to have her with us today to hear about their approach. Lana?
Thank you so much for having me, and thank you everyone for joining us today. I'll start by saying that, sure, it's not novel, but there's numerous headlines and research about AI. And whether you love it or hate it, I'll say that probably all of you are proficient users of AI, even if you don't realize it. Just think about it, whether it's unlocking your phone with your face recognition or leveraging Google Maps to get you to a point that, to get you quickest, find the best route for you to get somewhere, or even enjoying predictive nature of Netflix that recommends shows based on your preferences. We've come a long way in the last 70 years and have become very good at reaping benefits of AI. And although it's been around for decades, it wasn't until recently, especially as Michael mentioned with the latest developments in the generative AI tools such as ChatGPT, that it captured public's imagination, as Michael said, consumed the oxygen in the room, and truly got the attention of a lot of people. But what about AI within the healthcare space? Let's jump to the next slide. We saw in Michael's presentation that it has significant implications for every stakeholder within the healthcare ecosystems, from hospitals to physician groups to payers, pharmaceuticals, and so on. And we've already seen excellent applications of AI in healthcare. Medical imaging space, for example, AI can assist clinicians and radiologists by scanning MRIs and lab results for abnormalities, which in turn results in more capacity in their day. Or within the drug discovery space, I mean, imagine if we can accelerate cancer drug discovery from decades to months. And we already have pharmaceutical companies that are looking just at that. So there's a lot of opportunity. And think about the impact this technology can have on costs. As you can see on the slide, it's estimated that we could see anywhere between 200 to 360 billion in savings annually. Unfortunately, despite the enormous benefits and excitement around AI, adoption is very low, and that's a huge problem. In fact, less than 5% of healthcare organizations are using AI as of 2022. And that number is really lagging behind a lot of other industries. So today, there's a few things I'd like to cover. First, I'd like to focus on adoption challenges that almost every company will need to address if they're looking to leverage this technology. 2, provide you with techniques that you can leverage to overcome these challenges. And 3, I'll share some of the applications that we've been leveraging at GuideWell with the focus on improving our member outcomes, provider experiences, and really to help us drive better health for our members. So hopefully by the end of the session, you'll be able to leverage some of this content and accelerate adoption at your company and do it safely, which is most important. So why are we seeing, let's go to the next slide. Why are we seeing such small adoption rates? And I'm sure you can come up with a whole laundry list of reasons. But for many companies, a key barrier is human behavior. And this is where behavioral science comes in. If some of you aren't familiar with it, it's also known as behavioral economics. And it really just studies cognitive, emotional, and motivational factors that influence people's decisions and behavior. And if we can understand the root cause for certain behavior, we can then design behaviorally informed strategies to solve for those challenges. And I can tell you, as you can see on the slide, that fear drives a lot of our behavior. Fear of change, fear of the unknown, and rationally so, fear of algorithms. So each one of these is key to AI adoption, but we can fix that. So let's look at these in more detail. Let's go to the next slide. So fear of change causes us to have very strong preference for status quo or default bias. In this classic study where I'm showing you, a group of researchers looked at organ donation rates across different countries. And as you can see, proportions of individuals who enroll to be an organ donor varies substantially from the countries that are on the left and the countries that are on the right. And of course, for this to, for a lot of this to work, infrastructure needs to be in place. But the difference is that the countries that are on the left-hand side, individuals have to opt in to be enrolled to be an organ donor. Countries on the right, they're auto-enrolled to be an organ donor and they have a choice to opt out. So sticking to status quo is the easy option, even when it comes to such important decisions as whether to be an organ donor or not. So the law of inertia, in other words, is very much true when it comes to changes, and so is the case for AI adoption. So some of the solutions that you can think about when it comes to addressing status quo and people's preference to avoid change is, one, make sure you have clear vision and strategy, and ensure that you're engaging all the relevant leaders and stakeholders from different parts of the organization. This includes your legal team, cybersecurity, marketing, and other business functions. But basically, you need this group to make sure you can prioritize and identify high-value use cases where you can apply AI. And also, it enables you to coordinate and implement use cases safely all across your organization. Second strategy is to really make sure you have an effective communication strategy to ensure alignment across the company and making sure everybody understands what you're trying to achieve and why you're doing it. Even in the communication strategies, you can leverage some of the behavioral principles. For example, rather than saying we must adopt, you could say, what happens if we don't adopt, right? Because we know that people are more likely to engage when they're missing out on something or they're losing something. So again, how you frame your communication and your information is important as well. And lastly, we know that education does not necessarily lead to action. So you need to make sure that you provide tools to your employees that they can play with, that they can experiment with. In other words, make the use of AI a default when possible. And if we go to the next slide, let's look at the second fear, which is the fear of unknown. Here's another example from behavioral economics. If I were to ask you, would you rather take $500 guaranteed, or would you rather take a gamble, which is 50% chance of getting $1,000 or zero? Economically speaking, they're equal, right? The expected value is different. However, because of our preference for certainty, majority of us would go for the certain option of $500. Well, similar situation happens when it comes to AI adoption. There's a lot of uncertainties. Will it take your job? Is it the right investment? Is it too risky? So it naturally causes us to freeze and may lead a lot of individuals to say, hold on, I'm just going to wait and see, and miss out on all the benefits and opportunities. So again, as an organization, it's important to make sure you understand what employees are feeling. So potentially do a pulse survey to understand where they are, what their perception is. Then you can create targeted education to address some of those barriers. So for example, we have seen that AI as a job displacement is a big barrier. So again, rather than focusing on that, you can truly educate people that it will augment your role, right? Not necessarily replace, and so forth and so forth. And last but not least, I will say important thing is to make sure you upskill employees. So to ensure not just long-term success, but also to give them confidence and familiarity with this technology. So they're not afraid of it, but instead they're actually welcoming it and want to use it. And let's move on to the next slide and look at the last fear. And that's fear of algorithm. And Michael previously touched on that as well. And it's a legitimate concern, right? Related to potential biases on machine-based decisions that could be wrong or discriminatory. So it's not surprising that intuitively our reaction is to perceive AI as scary. And of course, that lack of trust hinders adoption of AI. But in reality, if you think about it, AI, unlike humans, does not have innate predisposition to their personal experiences opinions, and beliefs to influence decisions. AI is a direct product of our creation, right? So bias can come from poor training data, which is human generated. It could be due to poor algorithm building, which is again because of us doing poor building and poor testing or poor monitoring practices. Again, human has a control over that. So for AI to be without bias, we need to ensure that we're not introducing that bias and creating biased algorithms. Again, that's a super important element. And to make sure that that happens, we need to ensure responsible AI adoption is key. For that to happen, you need to have governance, you need to have controls in place, and ensure you have things like transparency and clarity for stakeholders on when, where, and how AI is used. You need to make sure you introduce fairness. In other words, have processes in place to ensure AI output and decisions are free from bias and discrimination. Another important feature is to make sure, especially for us as a company, human oversight, right? Make sure you include a human in the loop for every step to make sure everything is done properly. You have to figure out how to address risk management as well as privacy, and make sure you have robust AI systems that behave reliably. So those are all very important. Let's jump to the next slide. Now I'll turn to share with you a little bit about our AI portfolio that we have at GuideWell. So we've actually been successfully employing AI tools for quite some time now. And really the intent is to improve our member and provider experiences and help drive better health outcome. So within the predictive analytics space, I know Michael shared, that even though generative AI is dominating the space right now, there's still a lot of different AI capabilities that we can leverage. So we've been building and leveraging machine learning models to help us better identify members who could benefit from tailored education and clinical care, and ensure that we're proactive with our engagement efforts. For example, we have a preventable emergency room model that helps us to identify members who may benefit from education and resources on where to seek care when and if they need it. So for example, if somebody goes to ER every time they have a skin condition flare up, they may find it valuable knowing that they can resolve that via a teledoc or a virtual solution, which means quicker and better and more personalized care for our members. Another example is pre-authorization approval. So in 2022, Florida Blue actually became the first US payer to automate lengthy prior authorization approvals through AI-powered clinical reviews. And in terms of results, we've been able to streamline the reviews of 75% of prior authorization requests with AI, which enables a lengthy turnaround time on approved decisions within 90 seconds, 90, so that's 90. This allows us members to get to their next step in their care journey much quicker. And at the same time, our clinical staff spends less time on admin functions and more time on patient care. And last but not least, generative AI. We obviously know or have heard many times this is supposed to be the most transformational technology we've seen. So what we've done at GuideWell, we already stood up an internal capability. It's ChatGPT-like tool for employees to use and to innovate. We are already seeing excellent benefits of using this technology, and the ultimate goal for us is to leverage the latest tech to ensure we create seamless and personalized experience for our members, that we enhance care, health equity outcomes while optimizing cost and operational efficiency, and doing it safely. So if we go to the next slide, in summary, AI has the potential to transform industries. And if responsible AI is important for your company, here's a summary of items to think through to ensure success. First of all, structure. As I mentioned before, it's crucial that you convene a cross-functional group of company leaders and engage the right stakeholders. Training. Focusing on education and building technical capabilities on upskilling your workforce not only ensure long-term success, but also make sure your employees are comfortable with the technology and provide clear guidance on how to use that technology. Ethics. Again, ensure ethical and responsible AI adoption and use. So make sure you develop guidelines, policies, address concerns such as privacy, security, accuracy in the models. Technology Of course, assessing your company's technical capability is going to be very important if you're leveraging the latest and the greatest. And for some companies, it might be worthwhile to partner with the right companies to accelerate execution. And if we go to the next slide, I'll end by saying that for us as a company, by taking advantage of AI responsibly, we aim to improve access to care as well as health equity, make healthcare more affordable, reduce admin workload for our clinicians, and hopefully you can leverage some of this content to accelerate adoption at your company, and most importantly, do it safely. Thank you so much.
Thank you so much, Lana, for helping us understand how AI is being used to improve member and provider experiences and help drive better health outcomes. Next, we're going to move into our discussion on the ethical and legal challenges associated with integrating AI into healthcare. And we will hear from Glenn Cohen. Glenn is the faculty director at the Petrie-Flom Center for Health Law Policy, Biotechnology, and Bioethics, and a deputy dean of the Harvard Law School. Glenn is one of the world's leading experts on the intersection of bioethics and the law, as well as health law, and his current work focuses on the areas of medical AI, health information technologies, and research ethics. We're so grateful to have Glenn with us today. Glenn?
Thank you so much. Hopefully everybody can hear me. Next slide, please. Title slide. I often say that my job is to bring the doom and gloom because I'm dual trained as a lawyer and as an ethicist. Next slide, please. These are just some of my disclosures and conflicts. Next slide, please. I want to just start by kind of giving you an overview about how I think about how legal and ethical issues creep up into algorithm design, and it's particularly for machine learning. And I often think about this as the phases necessary for building one of these models and the idea that there are issues that arise at each of those stages of the life cycle. So first, in the first phase, acquiring the data, among the issues, where does the data come from? Are you getting consent from the patients whose data you are using? How are you stripping identifiers? Is that sufficient? How representative is the data? Is the data diverse in racial and other ways to serve the needs and context in which it will be deployed? What kind of governance opportunities are you offering patients? In the second phase, building and validating the model. How do you know when a model works well enough that it can be used on real patients? What standards of validation should be put in place? Who's going to be doing the validating, and how do we know we should trust them? How do you balance intellectual property protection in the form of trade secrecy against transparency needs to make sure these things are actually working? In the third phase, testing the model in real world settings. What, if anything, will patients be told about the fact that AI is being used to partially direct their care or reimbursement? Do you need a separate informed consent for this? Can patients opt out? How do we handle liability? I'll come back to both of those in a moment. And which regulator or combinations of regulators are best fitted to oversee this area? And finally, the last phase, broad dissemination. It's great. You've got a model that actually works. It's helping patients. And now you have a question about whether it's being equitably used. So do all patients who contribute data to the building of the model get its benefit? How do you make it commercially viable while also ensuring that there's equitable access? Next slide, please. So I mentioned this already in terms of liability, but I want to emphasize at the outset that there's been shockingly few cases about liability for medical AI, and most of the ones we've actually seen have been about surgical robots, where arguably it's not really the AI that's causing the distinctive issues. Now, it's possible there's a large gap between what we observe in the reported cases and what's actually going on. Maybe there's a lot of settlement. That's possible, but in general, my own takeaway and what I would leave you with is that people probably overestimate the importance of liability issues in this space given the data. But still, we should try to understand it. So this is a paper I did with Gurka and Price in JAMA. And essentially, we're looking and working through an AI recommendation to a physician, whether the physician adopts it, and the idea that it either harms or does not help the patient as much as what the physician would have recommended in the absence of AI assistance. And the question we're interested in is, who's liable when that happens, when there's an adverse event? Even when medical AI works well, it's not infallible. Sometimes patients will be injured as a result. And in general, in the US, to avoid medical malpractice liability, a physician has to provide care at the level of a competent physician within the same specialty, taking into account available resources. So we call the standard of care. What happens when you introduce an AI algorithmic recommendation as part of that process? And the figure we have here represents possible outcomes for a very simple toy case. So we're imagining a binary, and AI recommends the drug and dosage for a patient with ovarian cancer. And if you assume the standard of care would be to administer 15 milligrams per kilogram every 3 weeks of the chemotherapeutic agent, the AI, for a particular reason for this particular patient, recommends a larger dose. We examine essentially in this paper what could happen in terms of liability depending on what happens next. And I guess the takeaway I really want you to have is that last column with the color coding. It's stop sign color coding, so red, yellow, green. Under current law, a physician faces liability only when she or he does not follow the standard of care and an injury results. Those are the red boxes in the figure. And what's important about that analysis is it's just that the implication for physicians is as long as they follow the standard of care, they're going to be okay. And thus, the safest way to use medical AI from a liability perspective is as a confirmatory tool to support existing decision-making processes rather than as a source of a way to improve care. So I was going to do it anyways. The AI told me to do it, and I'm very happy about this. Well, that might be comfortable for physicians who are seeking to avoid liability, but it's terrible news for medicine because it's precisely in the cases where the standard of care is inappropriate, and the AI tells us so, but that's the cases where there's actually an advantage to using the AI and the possibility that we'll actually do better. And so that's a real problem with the current design of liability. There may come a time when it becomes actually liability risking not to use AI because AI becomes the standard of care, but we're not there yet. I'm happy to talk more during the Q&A about hospital liability, about developer liability. But now if I can move on to the next slide, please. And that is questions about informed consent. Do patients have a right to know about AI's involvement in their care, and under what circumstances and what details? So suppose to use a case study from reproductive medicine, you're a patient undergoing in vitro fertilization, you have multiple embryos, you're deciding which to implant. Your physician recommends a particular embryo and gives you some reasons to do so. It turns out, though, that your physician doesn't disclose they arrived at this decision in part based on a machine learning system, which recommends this embryo based on molecular imagery, analysis of your personal characteristics, and other factors. Is it a problem that your physician hasn't told you that was the basis in part for the decision? What if the physician actually chooses to overrule, quote unquote, an AI system recommendation and the physician fails to tell you that? Have they violated your rights of legal or ethical informed consent? Come to think of it, when you last saw your own physician, do you know whether an AI or ML system was used and involved in the care decision making? I have on this slide a paper we just did a couple months ago on a mental health chatbots for adolescents, where some players have used generative AI to help generate responses or at least suggest responses. There's actually a famous case in Belgium where an AI chatbot encouraged a man to end his life, and unfortunately, tragically, he did. Is that the kind of thing patients have a right to know that AI is being involved when they're dealing with an AI? Is this like failing to tell a patient that a substitute surgeon is scrubbing in, which our case law tells us is a violation of informed consent? Or is it more like failing to tell your patient that the reason you recommended a particular course of action was because of this black box up here, which included your memories from a case you saw in residency, a lecture you vaguely remember from medical school, and the last 10 patients you saw that were somewhat similar that are influencing your thought process? What is the right way to think about how AI works here and our duties to disclose? And by the way, that little cute seal on the slide is Paro, the therapeutic robot. He's sometimes used with patients in declining cognition due to age, and he's cute and he's cuddly and they love him and they treat him like a pet, but he's also a little spy because he reports back all sorts of information to physicians. How do we handle the kinds of cases involving Paro, which have vulnerable populations that may not understand, even if we tell them, the limits of what we're doing here? Next slide, please. So where does the data to train models come from? A lot is from EHRs. Is it a problem if we don't explicitly ask patients to share their data? And this is not just a theoretically interesting question. The University of Chicago and Google were recently sued into class action, alleging that they released patient EHR data with a timestamp that was otherwise de-identified, but it allowed Google, with its ability to geolocate patients based on phone data, to actually re-identify patients, and that violated HIPAA. There are many such lawsuits going on right now. I'm actually an expert witness in a couple of them. And next slide, please. The problem with the US approach to health privacy is it's very sectoral. HIPAA demonstrates one of the problems with that approach. HIPAA attaches and limits data protection to traditional healthcare relationships and environments, but the reality of the 21st century is that HIPAA-covered data forms a small and diminishing share of the health information stored and traded in cyberspace, as we try to show with this figure. Most of the stuff is below the waterline. And to put the point more forcefully, in the future, the data that best predicts our health may not be healthcare data, but instead data about our social media presence, online shopping, et cetera, et cetera. In one particularly fascinating illustration, a study used machine learning to try to diagnose depression from Instagram posts and showed that Instagram posting habits, filter choice, and changes of that was actually a very good predictor of depression, much better than many people would have complicated. And while most of the data privacy discourse thus far is focused on patient privacy, one very important to think about is about the way it reveals a lot about physicians. How well are they doing their jobs? Are we reimbursing them appropriately? Is there problems with their practice style? So it's not just patients that may feel surveilled, but also our physicians. Next slide, please. So I know the foundation is going to have an entirely different session on equity and bias, so I'll just whet your appetite for it. We can chat more during Q&A. What I want to suggest is that the problem is actually much worse than you think. Most people think of, okay, well, the data set is not very representative of the population. I often joke, as a mid-40s white guy in Boston, I'm dead center in most data sets used to train medical AI. Not so for women who are over 60, who are African-American, living in the rural South. And so often people think, okay, well, the problem is that the app has not been trained on the right data set. And that is a major problem, but it's one to wrap your head around. It's not that hard. Hard to fix, easy to conceptualize. The problems that we can't see that are much trickier, and Ziad Abelmari was mentioned before as one of the recipients of funding, he has this great paper that I have over here on the slide, one of the best done and most famous examinations. And what they show is they take a hospital readmission algorithm that's widely in use, meant to find patients most in need of follow-up care during discharge. And they show it favored white patients over black ones at the same level of sickness. Why? Not because the data set wasn't representative. It's because there are differences in care delivery and care-seeking behavior between these populations that mean white patients are just much more expensive than black patients. To simplify, the algorithm was told to use health costs as a proxy for health state, which is a decent ex-ante design choice, but one that results in favoring white patients over similarly sick black patients. This problem gets worse when you go beyond race, sex, age, which we can think about and try to train and try to test for, to think about all the other sources of variations in populations. But as I often say, it is true that medical AI often makes mistakes, cannot explain how it reaches conclusions, and is biased, but the same is true of your physician. So the real question is, how much of an improvement can we make on these scores by medical AI? And how do these errors distribute between populations we care about? Next slide. So this is my last substantive slide, and I'll stop here. And that's just to say, as bad as I've made the problem sound, it's actually even worse than you think. Why? It's because what we call in this paper in Science and elsewhere, the update problem. Even if as a hospital system or a regulator, you check all this out, you're satisfied with all the answers, and that's true for the quote unquote factory settings. We actually want algorithms to be adaptive, to learn out in the world and on the job, in part because every context, every hospital system, every patient population is quite different. We wouldn't want one that's trained only for patients that look like X to be used in a place where patients look like Y. But then you have the following problem. As a hospital system, as a regulator, when does it change so much that you need to re-review, and how often do you do that? Now, FDA, which is really kind of very innovative in the space, is currently trying to get off the ground an approach called predetermined change control plans. Talk more about that in the Q&A. Very interesting, but I'm not entirely sure it's going to be an adequate solution, even if it's the best one we have. Next slide. And I'll just close by thanking some of the people who funded this, and thank you all for listening to me. And I'm looking forward to the Q&A. So thank you very much.
Great. Thank you so much, Glenn, for sharing your work and helping us understand the complexities involved in understanding liability, consent, and bias. We'd like to use our remaining time to engage in Q&A. I'm going to ask all of our panelists to come back on camera and off mute. Our audience can continue to submit questions in the console. And Glenn, wanted to start with a question for you, and also Michael. Michael had mentioned, the using medical devices that are using AI, and I know there's, a lot of discussion in the regulatory space about kind of what is the FDA's ability to regulate how medicine touches AI, and it's one of the hot topics of the day.
Yeah, maybe I'll start, Michael, and you can jump in. Michael and I had the pleasure of working in the national academies and some stuff like this. Here's what I'll say is that actually, if you're hoping FDA will save you, put that hope away, not because it's not an expert agency, because the ambit of what it actually reviews is a small portion of the medical AI out there. And that's because of the way Congress has acted in the 21st Century Cures Act to pare back a bunch of FDA's authority, FDA's own decisions and interpretations of that authority, and then also the discretion it set itself and what it's chosen to review and not review and how it's structured things. So it's typically things that are built into the devices. Those are more likely to be reviewed by FDA, but actually the vast majority of medical AI being run, and also all the stuff that's being run for administrative purposes or insurance purposes and the like, FDA is not looking at this. So my own view is that we actually really need to have a lot more mini FDAs in institutions, and for them to be public and transparent about the way they're thinking about this, because the agency, as good as it is just not set up currently to do a vast majority of this kind of review.
Yeah, thank you. Yeah, and so I think that covers most of the waterfront. I think the only thing I would add to that is I think there are some other players stepping in. Health and Human Services and the Office of National Coordinator are stepping into a portion of the vacuum to try to give guidance around AI that's integrated specifically with electronic health records and clinical decision support. And so that's one area. Yeah, you actually see the Consumer Protection Agency stepping in on some of the entertainment, the non-medical use pieces, although it's a little bit unclear to me exactly how that is playing out. So I agree that there are gaps. I feel like the change process that the FDA is proposing is a step in the right direction to help everyone concretely think through when you're implementing an algorithm that's either continuously updating or updating in increments, how you think about making sure to maintain that properly. So.
Great. And Glenn, I know we got a little into generative AI. I know you had some more on that. We had a question about some of the administrative uses of generative AI and how they might carry lower risks, but what should be disclosed about how such models are used?
Yeah, so I mean, I think the administrative bucket is kind of super interesting, because I think if you ask 10 people what falls in the bucket and what doesn't, you might get 10 different answers. So one I'm very interested in is my chart right now. As people know, because of changes Congress made, we're all getting our test results almost immediately before physicians have seen them. So patients are now constantly emailing their physicians over my chart. And there are some hospital systems that are experimenting now with having AI do the first draft of the response to that. And so, that seems like a relatively low risk. It has human in the loop. It looks administrative. I will say I can imagine use cases where actually a patient gets a response and the physician has looked it over lightly, but in fact, the response causes the patient to engage in some kind of behavior that's really problematic, or not engage in some behavior that isn't. So to me, that's an interesting test case. And whether disclosing to patients, so I think the vast majority of patients are unaware that some of these messages are at least initially drafted by an AI. And one interesting question is, why aren't we telling them? Should there be a disclaimer on each one, the way there's kind of discussions about having disclaimers on AI-generated images, that AI generated this message? So I think that's a very interesting use case.
Great. Lana, we had a question for you, if you could speak to, some of the challenges about the data and, the data that you're using for the predictive analytics and just, general issues with data and quality.
Yeah, absolutely. And that's a super important question. I mean, everything that we do within AI depends on the data quality. So we have a very solid data governance in place and quality controls in place. And that's #1 priority for us as a company, to ensure that we have the right, sample groups, the right diversity in there. So we even, well, interestingly, we're even leveraging or exploring some use cases where we can leverage generative AI to extract social determinants of health information from clinical notes. And that, as you can imagine, I mean, there's research that indicates that more than 92% of social determinants health information can be extracted through clinical notes relative to traditional methods by just looking at, at the codes within the structured data. So ICD-10 codes. So that's another part of it. So how can we enhance our data? How can we extract as much as possible that we know about our members? And again, if we think about health equity, that's the sort of data that you might see in the clinical notes or provider and member interaction, right? So old text data. Now with this latest technology, we can enhance and do much more and understand our members much better. So not only are we thinking about quality and where the data comes from, we're always thinking about how can we enhance our data sets that we're truly using to, enhance predictive modeling, as well as leverage AI to enhance other AI tools that we're leveraging. Excellent question.
Great. I had another question for you. If you could talk a little bit more about the employee-facing Gen AI tool that you talked about, and
yeah, absolutely.
Is it like the one more on the administrative side, clinical side?
Yeah, absolutely. So another great question. So we have managed to get the right skill set and get the tool in-house. In other words, we have a tool that's within our company walls, which means it's secure. The data never leaves our company walls, which was a huge priority for us, given that we're, a health insurer. So we want to be very cautious about security in our members' data. So even though I know a lot of companies, within marketing and communication domains, they can easily go ahead and leverage publicly available, ChatGPT-like capabilities and different models, we have to be clever about creating our own infrastructure and setting up architecture in-house to make it possible for our employees to go in and explore it. And as OpenAI did with their tool, it pretty much opened it up and let individuals figure out what are the innovative ways they can leverage it to enhance their productivity and what they do on a daily basis. And that's the approach that we took as well. So really training our employees, making sure we have all the guardrails in place, conducting requirement training, risk assessments, security assessments. So we do a lot of due diligence and stand up a lot of guardrails in place before we let everybody use it. But as you can imagine, the use cases are very diverse, right? We have different teams across the enterprise getting very creative in terms of what they can do. Some are already, quantifying efficiencies as we speak. Some are, creating innovative capabilities that we haven't had at the company before. And whether it's, for somebody who codes or who writes, or even our clinical teams, now we can create, for example, we're testing out, can we create automated clinical notes that patients can take home with them as a result of interaction between the provider and the member and the general clinical notes that we have. So we're really trying to automate a lot of the solutions. And again, as a result, not only improve members, well-being and access to health and health equity, but also our employees' well-being as well, because now they can focus more on supporting, our members instead of doing repetitive tasks.
Great. We had another question about workforce shortages. And I know, like Michael, you spoke about how AI can be used to help providers and manage, changes and just the immense amount of clinical guidance out there. Lana, you mentioned kind of cutting down on the administrative side or making it more seamless. How do we anticipate AI advancing to help bridge the disparity of, the shortages that we're having in healthcare providers?
Yeah, it's a really good question. I mean, I think part of this isn't going to be addressed with AI. I think some of this is at a national policy level with medical education and salary reimbursement and a lot of other facets. I think where AI can really help, like something I'm actually even personally excited about is ambient AI. So the thought that I could sit in my room with my patient and actually maintain eye contact the whole time and have a conversation without any typing, other than to look maybe at a screen for lab data or something, and then it generate the narrative note. I look at it a few minutes, make sure it's right, and I'm done, is transformative. I've talked to a few providers who are in pilots with these, and it's saving them like over an hour or two a day from what is sort of tongue-in-cheek called pajama rounds, where you're at home doing the rest of your clinical work. And so right now, that looks to be one of the most amazing opportunities for frontline providers. And I have some other examples, but I'll pass the baton.
Yeah, I definitely agree, and I would even extend that use case, because it's not even just the interaction, it's even before the interaction. Rather than spending a lot of time reading through the notes of what happened with the patient in the past or the history, imagine you have a beautiful summary with all the elements that you need done for you that you can glance over, and you have all the information at your fingertips immediately. So I think it's the whole experience. And even after the interaction, like I was saying, you already have a beautiful report or something nice that you can give to the member so they don't forget what was discussed and what they're supposed to do. So I think it has a lot of impact, not only on the provider, but also the outcome for the member.
Great.
Maybe I'll just jump in here and just say something slightly more cloudy on this, which is to say I'm somewhat ambivalent about this for the following reasons, right? On the one hand, I think what I refer to as the democratization of expertise is great. The idea that we could take AI and give a lot of people who are currently not accessing the healthcare system something that allows them to get an on-ramp or to have something is really positive. On the flip side, I do kind of worry about this idea that we kind of have highways, and there's one highway that you get on if you have great health insurance and you can see a physician, and there's another highway that we put you on that involves kind of a lot of AI interactions and gatekeeping, and that we also exacerbate kind of differences about who actually gets in the door to a physician. So I think we have to be very thoughtful about the way we build this and roll this out, because it's a strong interest in kind of sorting patients in this way.
Oh, it's a great comment. And we had several questions about, can we afford to use AI in some of the foundational models, but can we afford not to? And, would be curious everyone's thoughts, and just, also some questions on how do we make it accessible for things like federally qualified health centers and, places serving underserved populations.
I can dive in on the last comment, which is actually, it's a huge concern right now that the computational resources, the clinical and technical expertise required to appropriately build, develop, execute, validate, and maintain these technologies is a really high bar. And there is a high risk right now of effectively creating bias and inequity from sites, individuals, institutions that cannot deploy that. So I hope that as long as we continue to have high awareness that this is a risk, and continue to reach out for ways to sort of disseminate and scale and make these deployable and safely in all environments, I think will mitigate it. But it's a significant issue.
Yeah. Great. Well, we are out of time. This has been such a fascinating discussion. Really appreciate our audience being with us. And as we mentioned, we'll continue the conversation, delving much more into health equity. So watch out for that upcoming webinar announcement. You can also find our research insight publication that summarizes the research of Ziad Obermeyer that was funded by NIHCM. I want to thank our excellent panel of speakers. Thank you for taking time to be with us today and sharing your valuable work and your perspectives. And thank you to our audience for joining and for your great questions. Your feedback is important to us, so please take a moment to complete a brief survey that will open on your screen. And just thank you all again for joining us today.